Weber triad is seen in the case of the insulinoma, where there will be hypoglycemic symptoms. Blood sugar is checked, low glucose will be there, sugar is given, symptoms will vanish, so which is the feature. Coming to hyperplasia, there is increased number of cells, increased total organ size is not there, and endometrial hyperplasia is an example, is what need to be remembered. Glycosuria without hyperglycemia is basically called the renal glycosuria, as all of you know very well. Now this is an interesting question. LR lamina of the midbrain gives rise to what? This is a question in LR lamina. Do you find it in adult midbrain or embryonic midbrain? It is seen in the embryonic midbrain. So knowing about midbrain in adult itself, neuroanatomy is a very rare scenario. In that, knowing about embryology of the brain is much more rarer scenario. Don't worry if you did wrong. So basically, if you look at the embryology of the midbrain, doctor, there are certain basal plates and LR plates. So the basal plates will be giving rise to the general sensory efferent nucleus of the cranial nerve 3 and 4, that is the oculomotor and trochlea, and general visceral efferent, that is the cranial nerve 3 Sedinger-Westphal nucleus, comes from the basal plate. Whereas the superior colliculi, inferior colliculi, red nucleus, substantia nigra, they all originate from the LR plate, is what need to be fundamentally remembered. So the LR lamina is associated with the inferior colliculi, superior colliculi, substantia nigra, whereas the Sedinger-Westphal nucleus is associated with the basal plate of the basal plate, but not LR lamina, is the underlying answer for this question. So I think juniors are very much with me that all questions cannot be read and all read questions cannot be reproduced. So all these disparities will be there, doctor. So enjoy with what that day calls you for. Now let's go to the next question. Osteomyelitis of the base of the skull. Probably femur we know, or any other location we can talk about it. All the way base of the skull. It is a topic in which subject? Radiology, radiotherapy, or ENT, let us guess. Otolaryngology talks about it. Basically there are 5 modalities by which the osteomyelitis at the base of the skull. Can it be a complication of any of the ear infections? Definitely. One of the complications of the otitis could be the development of osteomyelitis of the base of the skull. CT, MRI, technetium bone scan, gallium scan, and the indium labeled leukocyte scan, they are all considered to be the various modalities. Let us have 1-2 comments about each of them. CT scan for the base of the skull osteomyelitis. It defines the location, it defines the extent of the lesion, and it is also useful for determining the osteitis. And one pitfall is, unless the osteomyelitis has led to the demineralization of the bone by more than 30%, CT scan cannot be able to detect. So that is the fallacy in using the CT scan. You may miss the diagnosis of the osteomyelitis unless it has led to the degeneration and demineralization greater than 30% is what need to be remembered. So you can't wait until 30% is gone and then only start the antibiotic treatment. Then comes the MRI. It is only complementary to the CT. To know what is the soft tissue involvement, it has nothing to do with the bony window, hence it is also not useful. Then a positive technetium scan. It is absorbed with osteocytes and osteoblasts. Infection, neoplasm, traumatic bone repair, any of them typically can cause positive technetium scan. Generally it does not depend on the demineralization of the bone. So there is a reason, doctor, it is effective method of detecting the presence of the osteomyelitis of the base of the skull. There is one more contender, very close contender, gallium scan, which is also very much effective and a very sensitive indicator of the infection. And another important thing about the gallium is once infection is resolved, even gallium scan normalizes. So you can know whether my antibiotics are sufficient enough to take care of the osteomyelitis or not by doing a repeat gallium scan, is what need to be remembered. Then you have the, out of all, it is the indium and technetium specs considered to be the best modality to know, to diagnose and also to monitor the progression of the disease. So by that actually technetium and gallium are equal contenders. Some studies at least prove, ENT journals, that it is the technetium scan which is better. Now still it is left for your imagination and the examiner's key. If metanephrine is greater than epinephrine, it is pheochromocytoma. There is nothing to doubt about this question. So normetanephrine and metanephrine are the O-methylated metabolites of the norepinephrine, and the epinephrine is what need to be remembered. Now this is an interesting question. Primary biliary cirrhosis. When do you suspect this important diagnosis, doctor? A middle-aged woman coming with the pruritus also found to have the elevated alkaline phosphatase and the bile salt levels, and anti-mitochondrial antibodies are positive in her. You should suspect the diagnosis of primary biliary cirrhosis is what need to be remembered. Why it is called primary? If you do the ultrasound, there are no stones in the biliary tract. In spite of that, there is a cirrhosis developing. So there is, if the stones are there in the biliary tract and it led to the development of cirrhosis, then it is called secondary biliary cirrhosis. So now let us talk about the primary biliary cirrhosis. 25% of cases are incidentally diagnosed during a routine blood evaluation. Suddenly you found that bile salts are high, no pruritus, asymptomatic individual, then comes out the diagnosis. But out of the symptomatic people, it is the fatigue, which is considered the first reported symptom in 65% of cases is what need to be remembered. But why there is a fatigue? Basically, we are energetic or we are dull. Who is deciding? Hypothalamus and pituitary axis. In the primary biliary cirrhosis, it is the interleukins, 1, 6, tumor necrosis factor, etc. will go to the hypothalamic pituitary adrenal axis and will cause abnormality in that, and it is considered to be the pathophysiology of the fatigue that we see in the case of the primary biliary cirrhosis, where it is 65% most common symptom. Pruritus is found only in 55%, so it is not the most common feature, and it is a severe pruritus. But is there any relationship between the bile salt level and the degree of the pruritus? Generally there is no relation between the two. And it is the opioidergic tone which got increased in these patients is considered the underlying mechanism for the development of the pruritus is what need to be remembered. So endogenous opioid peptides, they become upregulated in the primary biliary cirrhosis patients and they lead to the development of the pruritus to develop. The right upper quadrant discomfort is a problem in about 8 to 17% of patients. So that is all the story when it comes to the symptomatology, fatigue, pruritus and right upper quadrant discomfort. Coming to the clinical signs, hepatomegaly 25%, hyperpigmentation 25%, Sicca syndrome can be found in about 50 to 75% and Kaiser-Frisker rings can also be found. And jaundice is found in only 10% of cases, that too the late cases of primary biliary cirrhosis. So it is not an early feature, jaundice, it is a late feature is what need to be remembered. So fatigue is a presenting feature is definitely the true statement. Pruritus is not the most common symptom is a very well-known truth. So B becomes the answer. Jaundice is only a late presentation and carries a bad prognosis. And the fat-soluble vitamin deficiency is a very well-known factor and a feature seen in the primary biliary cirrhosis is what I want to underscore to all of you. Now if you do the LFT, liver function test in primary biliary cirrhosis, a very good number of cases you will come across while doing your housemanship and post-graduation. Only thing is you need to have this diagnosis in your mind, otherwise it will miss you. So what we need to remember is the aminotransferases are identified to be elevated in most of the cases of primary biliary cirrhosis. And a significant elevation of alkaline phosphatase will be there. And only when cirrhotic stage is reached in the primary biliary cirrhosis, then only the bilirubin become elevated. If the bilirubin is elevated, it is an ominous sign of the disease progression and it is the indication that liver transplantation need to be done for that patient is what need to be remembered. At least in all the cases of primary biliary cirrhosis I have seen, they come by the time already jaundice is there. And unless you are having 15 to 20 lakhs in your store, you can't afford to go for a liver transplant, or you must have some kind of government fund, relief fund must be there, otherwise you won't go. So generally it was a sad experience of writing the post-mortem reports for the patients, though the diagnosis was clinched, but they came in a very late stage. Now coming to the complications of the primary biliary cirrhosis, it can lead to osteoporosis, fat-soluble vitamin deficiency, esophageal motility problems can be there, hypothyroidism can develop, hepatocellular carcinoma is a risk because they have cirrhosis, asymptomatic bacteriuria can be there, they can also have transverse myelitis. Why? Because primary biliary cirrhosis is an autoimmune phenomena, same autoimmunity will also affect the spinal cord also, hence transverse myelitis as another autoimmune manifestation can be there. Same primary biliary cirrhosis can have autoimmune thrombocytopenia and xanthomatous peripheral neuropathy. They are all the complications associated with the primary biliary cirrhosis is what need to be basically remembered. So now let us talk about the tetrahydrobiopterin. So basically it is a cofactor in the synthesis of nitric oxide. Nowadays too many things are linked with the nitric oxide. It is also important for the conversion of the phenylalanine to the tyrosine, because phenylalanine hydroxylase has tetrahydrobiopterin. Tyrosine to the L-DOPA conversion is required as a part of tyrosine hydroxylase. Tryptophan to 5-hydroxytryptophan, because it is a component of the tryptophan hydroxylase. And any defect of this tetrahydrobiopterin is implicated in the phenylketonuria of the type 4 also, is what need to be remembered. And similarly, because it is associated with the L-DOPA synthesis, some of the dopamine responsive dystonias, a very important entity in the neurology. Patient comes with a lot of dystonias. If you can't diagnose what is the underlying cause for dystonias, the rule is start him on L-DOPA. Luckily some patients with dystonias respond to the L-DOPA. One of the cause for it is identified to be tetrahydrobiopterin deficiency, is what need to be remembered. Hence phenylalanine to tyrosine, DOPA to dopamine, tryptophan to 5-hydroxytryptophan, that is serotonin. In all these locations it is implicated, is what need to be remembered. So is the homogenticide was there in the options, doctor? We could not recall, no problem. Was it an except question? It was not an except question. Then in all the three it is implicated, is what need to be remembered. Then vitamin C deficiency causes the deficiency of the proline hydroxylase, which is essential, and also lysyl hydroxylase also it is implicated. I am not yet sure about this transitional drug resistance concept. Now what is not a direct common cause of the death in pregnancy? Anyway, eclampsia, hemorrhage, pupil, sepsis, they are all direct causes. It is not the heart disease which is the direct cause, is what need to be fundamentally remembered. I think two more questions we have to recall. That is the amyloid deposition in the zona glomerulosa or fasciculata, one question. And one more question I could not recall. So I profusely thank all the students from Tirupati and Kurnool and Warangal and all these places. Immediately within 1 hour they have recollected the questions and sent. It is also an opportunity as a teacher to know whether the training session that we are conducting is of how much beneficial for our students, so that the next year we will improve in teaching also. And as a students, I hope that for the freshers it would be a useful process, because nothing is predictable in the state entrance. So thanks for the patient here listening.